study affects the selection of subjects in the study. Just remember this sentence. That is, you are wanting to study some variables, and it is the presence or absence of those variables which decides whether the persons are going to be in your sample. That is when Bergson's bias occurs. So when does this happen? This happens when you do not study the entire the general population, but you focus on a subpopulation. And the classical case is, without studying the general population, we study hospital admitted patients, or if you conduct a hospital based study instead of a population based study. And here the exposure to a risk plus the occurrence of the disease, when both are present, patient is more likely to be admitted to the hospital than an individual who just has the disease. So variables whose association, that is this risk which you are wanting to study, its presence or absence also plays a role in the patient being hospitalized. If this scenario exists, then we say it is Bergsonian bias. Now, this last sentence again will help you to understand what Bergson's bias is. It is the joint probability distribution of exposure and outcome, which is different in the hospital base, that is study base means the hospital based study, compared to the general population. Means the exposure and outcome together occurring in the general population, the probability is different, is usually less as compared to their coexistence in the population. Are you getting this? Because see, Bergson's bias we read often, but I have always found a difficulty in understanding, okay, what exactly it is. So one way of really remembering it is that the coexistence of the risk factor and the disease in the general population is different from the hospital where we are conducting the study. I will show an example and then we'll again confirm whether we understand this concept or not. Now, actually, Bergson did his study, if I remember correctly, on diabetes and cholecystitis. So, the initial few studies to understand this bias were coexistence of two diseases. Right now, this example again, which was done by Sackett, considers two diseases. So, the hospital, this particular investigator, what he did was he conducted a study in the community and in the hospital, and then brought out the stark difference between the two to highlight this kind of bias. So let us look at the picture in the hospital first. Now, when we look at the data from the hospital, now this is looking at the odds of the disease. There are two diseases considered. One is the disease of bones and organs of movement, so musculoskeletal disorders, and another is respiratory disease. So the research question is, what are the odds that individuals who have musculoskeletal disease have respiratory disease too? So do they have a higher odds of respiratory disease? And what do you see in the results?
4.06.
Yes, so the odds ratio is 4.06, means the odds of respiratory disease is 4 times higher in those who have musculoskeletal disease compared to those who do not have musculoskeletal diseases, right? Now, the same author does the study in the population. What do you see here?
The odds is 1.06, ma'am.
Yes, so the odds ratio is 1. So there is practically no association between these two morbidities. The individuals who have musculoskeletal disorders do not have any higher odds of respiratory disease. Those with and without musculoskeletal disorders have equal odds or risk of respiratory disease. Now, again, try and remember what we try to understand with Bergson's bias, and can you find out the reason why in the population there is no association, but in the hospital-based case control study, there is an association. Can you think?
And there might be a symptom overlap, like both diseases might be having overlapping symptomatology.
Okay.
There might be old age population.
Okay, I'll give you a hint. Now, what would you say? The percentages which I am showing you in the general population, this is the scenario, and the percentages are the numbers who have been admitted in the hospital from those in the population. This will help you answer the question.
Those who have both the diseases will have more odds of hospital admission.
Yes. So what this particular table is showing is that amongst those who have neither, neither the respiratory disease or musculoskeletal disease, 9% of them are being admitted. And of those who have only musculoskeletal disease, 10% are being admitted. Of those who have only respiratory disease, 7% are being admitted. But of those who have both the morbidities, 29% of those are being admitted. And now in this scenario, when you do a hospital-based case control study, you are getting a wrong odds ratio or a wrong estimate of the association merely because individuals with both the morbidities are more likely to be in the hospital. And that this is Bergson's bias, which is true for or can occur in hospital-based studies. Are you getting it here?
Yes, ma'am.
Others?
Yes, ma'am.
So the way to understand
ma'am.
Bergson's bias is, see, there is something different in the general population, but because your admission criteria are such that individuals with the exposure and the outcome, here the two diseases, they are more likely to be admitted in the hospital because the risk of hospitalization is more. That is why you are getting an association which truly does not exist in the general population. It is merely because of the hospitalization phenomenon, the criteria which decides hospitalization, that you are landing up with an association. This is Bergson's bias. So if you are asked a question about Bergson's bias, I feel you should be able to give good examples and give the principle of the bias which occurs. So this again is showing us that the topmost thing is what's there in the general population. So this is what is there in the general population, and this is what is there in the sample. So when you are sampling in the hospital, this group is more likely to be overrepresented. The cases with exposure are more likely to be admitted. Merely because of this phenomenon, you are finding an association in a hospital-based study. That is Bergson's bias. So for all hospital-based studies, you need to look at the potential of existence of Bergson's bias. Now, it is not just the cases with exposure. This can also happen. That is, in the population, the cases with the exposure are more. But compared to what is there in the population, the controls with the exposure could be more in the hospital. Now, this usually happens, supposing you want to study association of a disease with substance abuse, say tobacco or alcohol consumption. It is known that hospitalized patients, be it whatever may be the reason for hospitalization, the prevalence of tobacco consumption, alcoholism in hospitalized patients is more than the general population. So what will happen when you want to look at the association of your disease with these kinds of exposures? The controls which you choose for many of the diseases which you may choose as controls, the prevalence of or the presence of tobacco or alcoholism is going to be more than in the general population. So while this scenario will overestimate the association of exposure outcome, this will underestimate the association of exposure outcome as it exists in the general population. Are you getting me here? Because this is a little complicated.
Yes, ma'am. Yes, ma'am.
Others are others getting me here?
Yes, ma'am.
Yeah.
Ma'am.
So when you're looking at hospital-based studies, you should question whether the exposure status in cases and controls is going to be the same as that in the general population. And one has to be really super careful with hospital-based studies. So what are the solutions for Bergson's bias? Now, ideally, this kind of bias usually occurs in case control studies. So it's preferable to do community-based or population-based case control studies. But that is not always possible. So you will have to take up hospital-based studies. So some articles, they recommend that, okay, you choose your cases from your hospital, but choose controls from the community. But this solution will not work because this will, most likely it is going to overestimate your odds ratios. So the solution for a hospital-based case control study is, okay, you're choosing your case from the hospital, choose a control from the hospital, but do not do it arbitrarily. You have to look at controls who have similar hospitalization rates as compared to your cases. So this is again a bit tricky. So you have to look at the mechanisms in which the cases are being admitted and the various steps through which the controls are being admitted and the likelihood of admission being the same, and then choose your controls accordingly. So one has to be careful with not only the disease which you're choosing, because we have seen that that disease should not have any association with the exposure, but the chances of hospitalization, that is hospitalization rate, should also be very similar to your cases. That is another thing which you should note when you're doing hospital-based case control studies. Again, there is a recommendation that instead of prevalent cases, if you take incident cases, you can address your Bergsonian bias. But picking up incident cases is only going to handle the association of chronicity or presence of comorbidity. Now, incident cases means the case was identified after admission or on admission. Once the patient, it's a fresh case. It's not a case which is existing for a long time. So the period of that disease or existence of other comorbidities will not hamper the decision about hospitalization. So if you are worried that chronicity and presence absence of comorbidities could be associated with a bias, then it's preferable to consider incident cases. But again, you will find many articles talking about Bergsonian bias. If you want to know more about this bias, you can read those articles. But I've just given you a gist about what actually this Bergsonian bias, which is a kind of a selection bias, is, which is true for selection of cases as well as selection of controls in a hospital-based case control study. So at least, are you understanding something more than what you knew before for Bergsonian bias?
Ma'am, yes, ma'am. No, ma'am, I have a doubt, ma'am.
Yes, please.
Ma'am, will it apply for OPD patients also, ma'am?
No, this is for hospitalization. Hospitalized.
One day, I think.
Yes.
Okay.
But now see, if you think about how people land up in the OPD, what are the
Yes, ma'am.
mechanisms, right? So when
Yes,
you're
ma'am.
choosing your cases controls in the OPD also, the people coming to the OPD, the likelihood should be the same. Like, it depends upon your research question. What are your outcomes of interest?
Okay, ma'am.
Okay. So,
Thank you.
yeah. But this particular thing, this Bergsonian bias, is about hospitalized patients, the indoor patients, and because here the decision to admit, right, that is the decision which is affecting your exposure and the outcome both. Then this second one we're looking at is the Hawthorne effect. Now this name comes from this electric plant in Hawthorne in Illinois, where a study was conducted to determine how working conditions like illumination, rest pauses, humidity, etc. influenced worker productivity. So the first record showed that illumination or humidity, temperature, okay, if you improve, it is not showing any association. But when you look at more closely, right, I think it was showing an association. It was showing an association, I'm sorry. But when you look at it more closely, then the data showed that whether all these changes in the environment are made or not, the productivity increased. And this increase was not because of the changes in the environment, but merely because individuals were being observed. And this phenomenon of being observed brings about a change in the behavior which affects the outcome. This is what Hawthorne effect is. It is not the intervention, but it is mere observation of the individuals. So, how do you prevent this kind of effect in your studies? One is, if you extend so if you keep the observation period for a short period of time, then this Hawthorne effect will occur. But if you just extend observation period, then this, the effect of observation does not last long. People start acting naturally, and then you get the correct result. So if you observe people for longer periods of time, you can wash out the Hawthorne effect. And another thing, of course, is remote monitoring and not people not being aware of the fact that they are being monitored. Those are the kinds of monitoring systems, if you can put, then you can prevent Hawthorne effect. Are you getting me here?
Yes,
Ma'am,
ma'am.
what will be remote monitoring?
Remote monitoring means, it could be some camera, or it could be some indirect form of monitoring where people are not aware that they are being watched.
Okay, ma'am.
Yeah. So, like in your this thing, qualitative studies, there is participant observation. So, unobtrusive recording, one method I remember is somebody within, say, in this example of the electric plant, some worker is asked to note down whether the whatever observations are being made, which is not known to anyone else. So that could be another example of unobtrusive recording. So people are not aware that things are being recorded and are being observed. So that is also an example where it is unobtrusive. So you will have to find methods in which people do not change their behaviors. So basically this is behavioral research, that needs to be handled to prevent Hawthorne effect. Then you have, now this is more complicated, this is immortal time bias. Now supposing you have, two groups and you want to follow them up until some outcome occurs. Now this example is where you have two groups where people are discharged and one group is given a prescription which they have to get from the stores and start taking the medication. One group is not given any medication, and you are seeing how many of the patients in both the groups are readmitted. But the people who have been given the prescription do not go to the stores, medical stores, immediately after discharge. There is some time before they go to the medical stores and get the medicines which have been prescribed. Now, if you consider all those who have been given the medicine as the exposed group and those who have not been given the medicine as the unexposed group, you are committing this immortal time bias. So what this graph shows is that here at the top, you are including everyone in the exposed group as exposed and everyone here as the unexposed. But this period in the exposed group, they are unexposed. So this is known as the immortal time here. Whatever happens here actually is not in the exposed group. The person in this group has to not be admitted and has to survive till the person receives the prescription to be in the exposed group. So actually, when you are doing such kind of studies where you know that the exposure has not occurred at the time of making these groups, you have to consider the person time in the denominator. This is the solution for immortal time bias. Means this much period of the exposed group has to be put in the unexposed group, and the correct period for the exposed group has to be considered as the exposed period. This is a little complicated, but when you are making groups, you should ensure that the exposure period happens at the point of the time you have made the groups, if it is not happening, it is happening sometime in the future, then you have to consider person time and allot them in appropriate groups. Are you getting me here?
Ma'am, can you please repeat?
Yeah. Yes. See, this figure, what it is showing is that the study is patients are discharged. One group is given some medication, another is not given any medication, and they are to be followed up. And the time or the how many of those in each groups get readmitted is what we need to study. So patients are discharged, they are given, one is given the prescription, the other is not, and they are sent home. But the people who are given prescription in the exposed group do not get the medication immediately. There are some days before they actually go out and get the medication and start the medicine. But when you are doing analysis, if you include all of them as exposed, as getting medicines, you are committing a bias. There is going to be an error. So the period of the time when they are not exposed has to be considered person time as not exposed. Are you getting me, Reenal?
Yes, ma'am.
Yeah.
Yes,
So
ma'am.
look
Ma'am,
at
so like
yes,
when they are discharged, immediately they are not having the medication,
yes,
and
yes,
for like, so that is the main thing with this immortal time.
yes. So just because you have made some groups and you have given the intervention in one and not in the other, but you have to be sure that the exposure to the intervention has happened at the time you are assuming it has happened. If not, if it is happening later on, then you have to make those adjustments and you have to reallocate that time to the unexposed group. So you
Okay.
have to be careful about when actually the exposure happens. That is what is the take home message.
Yes, ma'am. Thank you.
Then these two biases. Now I'm sure you know about this. I have also written. You can tell me about this. This usually happens in studies where you are looking at the validity, predictive values for your screening tests. But this particular example is about when you're looking at the, you know, importance of the screening test, whether it should be taken up or not, and policy decisions are to be made. So usually we talk about validity and assessing the predictive values, but there are other aspects to a screening test where we want to see whether the effectiveness or the efficacy of a screening test where these two biases creep up. So can anyone explain or try and describe these, at least one of the biases? I'm sure you know about the lead time bias, which is shown in this picture.
Ma'am, I'll try and explain lead time bias, ma'am.
Yes, anyone you want, Siva?
Yes, ma'am. So, for lead time bias, actually suggests that there is an apparent increase in the survival time, ma'am. For example, because of for any condition, we don't have any treatment which is actually going to prolong the condition, the life of the person. But our screening test is going to diagnose the patient a little bit earlier. So that suggests that it apparently shows that the survival time is increased and the mortality is going to be decreased. But in reality, no such thing is happening. Only because since the screening time has been a little bit before, it appears as if there is an increase in the survival rate, ma'am. So that is the lead time bias, ma'am.
Yes, absolutely right. So
Thank you.
the example here is that supposing a woman is identified by screening and survives for 5 years, and another woman of the same age is diagnosed because of the symptoms after 3 years and survives for 2 years. So both of them actually have survived for the same age, right? But because you begin from the time of diagnosis, how many years the woman has or the individual has survived from the time of diagnosis, there this lead time bias creeps in. So there is an overestimation of survival time if you are looking at the time from diagnosis. That is known as lead time bias because you're shifting your starting point to the left for your screening test. Otherwise, actually, the survival time for that individual is not increased because of screening. Now, if one wants to prevent lead time bias, instead of survival time, you can look at the number of deaths which are occurring in a given period of time in both the groups. So if you avoid looking at survival time and look at mortality rates in the two groups for a given period of time, that will avoid such kind of bias. Another solution for lead time bias is to consider the point not from diagnosis but from the point of randomization or entry into a study. So if you're doing a study and you're randomizing women to one receiving the screening and the other not receiving the screening, then you have to begin your follow-up or consider the denominator from the point of randomization, not to the point of diagnosis either by screening or the symptomatic point which leads to a diagnosis of a condition. So that is lead time bias. What is length bias?
Ma'am,
Yes.
length time bias is like usually this happens with the screening test. Different time point screening tests will be conducted. In a case of carcinomas, if carcinoma is fastly growing and the time it starts to appear symptoms will be very fast in it. And in a slow growing tumors, the progression phase will be long and time for the symptoms to appear will also be very long. So if a screening point is conducted at a stage, the slow growing tumors will be identified through the screening programs, and it will give a false sense of the patients will have a longer survival time based on the time of identification, but which is not the true in the case.
Yes. So those which are more aggressive will have a shorter asymptomatic preclinical period and will not be identified through screening, because screening we are looking at apparently healthy asymptomatic individuals. So your screening is going to capture the slow growing tumors in asymptomatic individuals, and the assumption here is that the slow growing tumors are also going to lead to lesser mortality. So this kind of bias will also give a false sense of effectiveness for your screening test. So when you're looking at the studies which are reporting effectiveness of screening tests in terms of, say, improved survival, you have to consider lead time bias, and then whether they are looking at all varieties of cancers, all stages of cancer is what you have to look for when you are trying to rule out length bias.
Yes.
So what we have looked at is bias in terms of selection bias for recruitment, retainment, and information bias, reporting, and observer bias. And you need to ask questions at each stage and then find out mechanisms for preventing the bias. Now, just few examples before we end, because this will really again highlight some types of biases which we may not have looked at till now. This is a very famous study which I have taken in one of my classes, which was published in NAGM in 1981, a case control study on coffee drinking and pancreatic cancer. So cases are pancreatic cancer and controls are patients who are hospitalized by the same physician who is managing the patients with pancreatic cancer, and these therefore are more likely to have gastrointestinal disorders. But recruiting controls in this fashion is logistically easier, so these patients are recruited. So what is the problem here with the controls? There is a problem with the controls. What do you think is the problem? The exposure is coffee drinking. So this author, when this particular study was published, the first findings were that those, has anyone read the study? So there was a positive association between coffee drinking and pancreatic cancer, right? So there was a lot of reaction to this study, because this study was saying that those who were drinking coffee, they had higher risk of pancreatic cancer. So this study was looked at very, very closely. And then there was another study which was published, and this author was a co-author for that study, which showed that individuals with gastrointestinal disorders, they were more likely to give up coffee drinking because of their symptoms. And therefore, when you're looking at history of coffee drinking or current coffee drinking or history in the immediate past, there was less likelihood of coffee drinking in the controls. And because of that, there was a overestimation of the association of coffee drinking in patients with pancreatic cancer, or overestimation of the association between coffee drinking and pancreatic cancer. Are you getting this?
Yes, ma'am.
So the problem here is that the disease, gastrointestinal disorders which are picked up as controls, they are associated with the exposure. So individuals with GI disorders are less likely to drink coffee. Therefore, you find a positive association between coffee drinking and pancreatic cancer, and that is how this bias creeped in. Subsequent studies have not found any association between coffee drinking and pancreatic cancer, and so many of us continue to drink coffee. Now, can anyone comment on this particular? This is I think from some media report, where even the lead author has given us a bite. So, what is your comment about this report? The green bars, they are screen detected cancer, and the blue
Length,
bars are clinically detected cancer.
length time bias.
More than length, it is lead bias, lead time bias.
Lead time. Okay.
Yes, I think you meant to say lead time bias.
Yes.
Yes, so they are saying that the 5-year and the 10-year survival rates are better among those who were screened as compared to those who were detected through clinical, those who developed clinical symptoms and then they were diagnosed. So this is a example of lead time bias. So actually, you have just shifted the time zone for those who are screened to the left, and hence you get a longer period there, and it's not a real effectiveness of your mammography screening. What is this telling us, this example? So if somebody looks at this data and they say, okay, having intermediate exposure or working in this industry is protective, being a worker in this industry. So gas workers compared to the general population, working in the industry or even intermediate exposure appears to give protection. What is this bias? This is healthy worker effect. Healthy worker effect means those who are in employment are healthier as compared to the general population. There are two ways healthy worker effect happens. One is healthier people are recruited, and another mechanism is healthier people are more likely to be stay put in a particular occupation. And therefore, those who are in the occupation, when you are studying, those who are working, they are healthier as compared to the general population. So when you are making such comparisons, you will tend to get a protective effect of the exposure, which you should interpret very carefully. So what is the solution to such kind of a problem to prevent healthy worker effect? Instead of comparing to the general population, you compare to another cohort of workers who do not have similar exposure, might be in the same factory, in a similar industry, or in some other factory. Now, this again is an example of Bergsonian bias, where you have women who are, we want to see the effect of pregnancy, new pregnancy in HIV positive women, and look at the time to development of AIDS. So women who are pregnant and who are HIV positive, they are more likely to report with symptoms because they are pregnant and they are HIV positive. So the coexistence of these two phenomenon is more likely to catch progression of HIV to AIDS, and this can overestimate the effect of new pregnancy on progression. So this is a classical example of Bergsonian bias. Another example is So again, this is a question of which I think Ajit had asked, right, Ajit? So this is an example where
Yes,
again
ma'am. Yes.
it is not hospitalization. So coexistence, but seeking treatment. So if that is influencing the mere existence of your exposure and outcome is affecting seeking treatment, that can also bring in a bias. This may not be labeled a Bergsonian bias, but this coexistence is affecting capturing your outcome, then it will affect your study results. This is another example. Now you have to tell me what is the bias here. You have a case control study of opium use and bladder cancer. Now first is you are selecting cases, people who have bladder cancer. There itself, the question is, will you be able to recruit all patients with bladder cancer? All patients who are, you want to include everyone with bladder cancer, because that is one question you will ask in a case control study. Are all eligible cases included in your sample? But some of the people may not be ready to participate because they are having severe illness. So you may not have a true representation. Or when this, with respect to exposure, if you are asking a history of opium use in both cases and controls, there can be reporting bias. There can be social desirability bias. So when you're reading such reports or when you're planning such studies, you have to take into consideration whether bias can creep in. Another example here is opium use and squamous cell carcinoma, where you want to recruit friends as controls. The problem here is the use of opium in the friends can be very close to the use in cases. So this can underestimate the association between opium use and bladder cancer. So choose your cases, controls, and try to see how you can get authentic information about exposure. This is another example of left truncation bias. So you are asking history of night shift in the women in the nursing staff, and you want to see the association of night shift work and breast cancer. And you, at the time of recruitment, you are asking the question about history of night shift over past 10 years. And you find that there is no association between night shift for 10 years and breast cancer. But there can be a bias here, because if the effect of night shift occurs earlier, you are waiting for a 10-year period. But if the effect is happening earlier than 10-year period, you are losing out on the effect of exposure or on the risk of breast cancer. So that is known as left truncation bias. Another bias which can creep in this kind of study is that women who are now reporting 10 years, you are asking in the past 10 years, right? So these could be younger women. There could be older women who have been posted for night shift when they were young. And currently, those who are at higher risk of breast cancer, they may not have been posted for 10 years continuously for night shift. So this can affect your assessment of the estimate. So what I'm trying to say is, when you are planning a study, don't arbitrarily think of any cutoff for exposures. Don't take histories of exposure without considering these important points about the effect of exposure, whether it can be short term, long term, and when the exposure would have occurred, and whether the exposures far in the past could also have an impact on the outcome. So you have to consider different scenarios and then decide on the time period for which you are going to collect data for the exposure. Then if there is left truncation, you have to also look at the future, what's happening for the period of follow-up. So in one study for survivors of atomic bombs in Japan, the follow-up period was short. They did not find any association with lymphoma. But when the follow-up periods were extended, because there was a longer latent period, they could capture the effect only when they followed for a longer period of time. So you should collect, or you should decide upon the period of follow-up correctly to capture the effect of the exposure on the outcome. You cannot cut short the period of follow-up. Then this is another example. So this is where you say that, okay, I'm interested in urinary bladder cancer and its association with, say, micronutrient supplementation. So if you say I'm going to take all current urinary bladder cancer cases, all which are there currently there, say in a particular hospital, and I find a positive association between micronutrient supplementation and bladder cancer, I may erroneously say that micronutrient supplementation increases the risk of bladder cancer. But in reality, what is happening might be that micronutrient supplementation is associated with less aggressive cancer. They are surviving, and therefore you are finding a particular association. So you should learn to ask questions whether some such thing is happening when you find an association. Can someone comment on the controls? I have given some options for controls for this particular kind of study. The outcome is bladder cancer. So of these, which ones would you consider as appropriate controls? Would you consider those with orthopedic trauma to be appropriate controls?
Yes, ma'am.
Acute appendicitis,
Yes.
cataract, urinary tract infection, anemia, and COPD. What are you thinking when I'm asking you whether any of these is an appropriate control? When your cases are urinary bladder cancer and your exposure is micronutrient supplementation. One point which I mentioned was that the controls, these diseases should have no association with the exposure, right?
Yes,
So
ma'am.
if you think of anemia, COPD, there is a potential that they are associated with micronutrient supplementation. So these acute conditions which are there, they are more appropriate as controls as compared to the others. Again, this is esophageal cancer. Now, this is the last couple of examples. One, I'm talking about reverse causation. You are studying, okay, you're doing a case control study, esophageal cancer and opium use. Okay, and you find that there is a strong association with the odds ratio of 2, suggesting that, okay, opium use is a risk factor for esophageal cancer. But someone may say that this is reverse causation. That is, those who have esophageal cancer are using opium, right? So if you want to rule out reverse causation, you will have to reanalyze your data looking at those who are reporting use earlier than 1 year before, before cancer diagnosis, so that it's not the cancer which has led to opium use. So there are ways of checking whether reverse causation, but even after doing that, the association persisted, which meant that this was not reverse causation. And this has to be differentiated from protopathic bias. Now, this is the only difference here is that symptoms of undiagnosed cancer or any undiagnosed disease leads to exposure. That is protopathic bias. So it means here what it means is that if somebody has esophageal cancer and develops cough or some symptom and starts using opium before the person is diagnosed as cancer only because of the symptoms, then what will happen? If you do a case control study, you will consider that patients with the cancer had more exposure to opium, so opium has led to cancer. That is protopathic bias. Are you getting me here?
Yes, ma'am.
The subtle difference is in reverse causation, it is the disease has already occurred and then the person has been exposed. And in protopathic bias, we are saying the diagnosis has not happened. It is just the symptoms which has led to the exposure. And now when we are doing case control, we are saying that exposure has led to the disease, which is a bias.
Ma'am, 1 minute.
Yes, please.
I have
Yes,
a doubt.
please. Yes, Ajit.
Ma'am, right now the example is like they must have cancer, but they are not diagnosed. They start using opium because of symptoms. After that, they will be diagnosed, so they will think opium use lead to esophageal
Yes.
cancer.
Yes.
That is prototype.
Yes. That is
Yes.
protocol bias.
Okay, thank you.
Yeah.
Ma'am,
And then you see, when you want to exclude, you are saying 2 years. 2 years, before 2 years, whether they were using opium or not, because you want to rule out symptomatic phase. Yes, Dinesh?
second point, why should we exclude 2 years before patients also who you had used 2 years before also, ma'am? I understand that recent usage exclusion, but past 2 years criteria that I don't understand.
No, excluding any participant who had started using opium in the 2 years before receiving diagnosis means in the immediate past 2 years.
Okay, ma'am. Okay.
Yeah,
Okay.
immediate past. So 1 year is